Right. A'udhu billahi minash shaitanir rajim. Bismillahir rahmanir rahim. Now we are here in the 145th webinar of the Pakistan Medical Association, which is being held in collaboration with many other organizations, including Women Medical College, South Asian Association of Physiologists, Pakistan Physiological Society, Pakistan Association of Pathologists, and Medical Women Association of Pakistan. So we recite from Holy Quran to start with. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم يا أيها الناس قد جاءتكم موعظة من ربكم وشفاء لما في الصدور وهدى ورحمة للمؤمنين. ये सूरत यूनुस की आयत थी। मफ़हूम तर्जुमा है, लोगों तुम्हारे पास एक ऐसी चीज़ आई है जो तुम्हारे परवरदिगार की तरफ से एक नसीहत है और दिलों की बीमारी के लिए शिफा है और ईमान वालों के लिए हिदायत और रहमत का समान है। तो कुरान मजीद तर्जुमे के साथ थोड़ा ज़्यादा बाकायदगी से पढ़ते रहा करें। इसमें रूह की शिफा है, इसमें दिलों की शिफा है, इसमें बदन की शिफा है। ये हमारे लिए हिदायत है और ये हमारे लिए निजात का ज़रिया है। सदक़ल्लाहुल अज़ीम। Now it is our honor to introduce our speaker, Dr. Saqib Ali, who is a well-known neurologist. He is working as senior registrar at Women Medical College, Abbottabad, and his topic is very important clinically for the patient perspective, student's perspective, for every physician and for every practicing doctor, the diabetic neuropathy. Dr. Saqib Ali, please start. You are welcome, and you can start, please, your presentation.
Thank you, sir, for introducing me. I will just again repeat very briefly that my name is Dr. Saqib Ali, and I'm working as a senior registrar in Women Medical College, Abbottabad. So, as I told you before, the topic of our discussion today is diabetic neuropathy. Diabetes, as we all know, is a very common disease in our society. And according to the International Diabetic Federation 2025 latest report, about 31.4% of the Pakistani adult population has diabetes. That is a huge number, making it around 33 million of the Pakistani adults with the diabetes. And this makes Pakistan is the country with the highest population of people with adult onset diabetes globally. And diabetes, as we all know this thing that it causes a myriad of clinical manifestation, including vasculopathies, neuropathies, nephropathies, and the topic of our discussion today, the neuropathy. It is very common, but perhaps unfortunately as well, under-recognized complication of diabetes. And my focus today will be on how to identify it early, how to differentiate between the common patterns of the diabetic neuropathy, and how to manage these patients effectively in our clinical practice. So just briefly, I will go through this slide that we all know there are now as per the latest classification, there are many types of the diabetes considering the basic pathology. But in clinical practice, what we normally the classification that we normally use is the same: pre-diabetes, the type 1 diabetes, the insulin-dependent diabetes, and the type 2 are the non-insulin-dependent diabetes mellitus.
Please share the screen.
I'm already sharing the screen. Is there any issue?
Oh, no issue. It's visible.
Ma'am, kindly refresh your Zoom. It will appear on your screen. I think that's a problem with your internet.
My
We can.
internet or
No, ma'am's internet.
okay.
You are okay, sir.
Should I continue then?
Sure, sir.
This slide is showing rather old concept of the proportion of the diabetes. Before they used to say that around 90% of the patients after 20 years after diagnosis, they will have some manifestation of diabetic neuropathy. And only 10% of the patient, they will be neuropathy free. But as per the latest data, the things are a bit different. It is suggested around 55 to 60% of the patients will go on to develop diabetic neuropathy after 20 years of diagnosis, despite the intensity of the diabetic control. And of these 50%, around 20 to 30% will have a symptomatic disease. Discussing the common risk factors for the diabetic neuropathy, the deviation, as I mentioned before, is perhaps the most important risk factor for the diabetic manifestations. And it is said that about 50% of the diabetics over the period of 25 years will have some manifestation of the diabetic neuropathy. Other things that affect this progression of the disease, they include the glycemic control of the patient, low baseline serum insulin concentration. So it means that type 1 diabetics, they are more prone to the development of diabetic neuropathy over the period of time. Smoking and alcohol consumption, they are also very important factors. They contribute to the development of diabetic neuropathy. Just simple reminder that as tobacco induces vasoconstriction, so it precipitates nerve ischemia, and over the period of time, this causes nerve damage and development of diabetic neuropathy. Other demographic factors, age and male gender, they are also very important. And another thing is the height of the patient that I didn't mention here, because the more height you have, it means you have longer nerves, and the longer nerves mean you are more prone to develop diabetic neuropathy, because uh, as I will discuss in the pathogenesis later, it affects such patients are more affected by the impaired axonal transport. Other risk factors, they include hyperlipidemia, mechanical injury, the weight status, and genetic susceptibility. More likely, this patient with the type 1 diabetes. Now, this is a rather a busy slide, but I just included it because I just wanted you to give an overview of different patterns of the diabetic neuropathy that we can see in our patients. The briefly classifying it, there are three major types: the diffuse neuropathy, the mononeuropathy are mononeuropathy multiplex forms, and the radiculopathy or polyradiculopathy are atypical forms. I will discuss these in detail later. But just wanted to say one thing here, that the non-diabetic neuropathies are also common in diabetic patients. These include the pressure palsies. Diabetic patients are more prone to the pressure palsies. They are also more prone to development of chronic inflammatory demyelinating polyneuropathy. And uh, this is an important diagnostic dilemma in such patients as well when they present with CIDP. Uh, Another thing is they are more prone to develop radiculoplexus neuropathy and acute painful neuropathies. These acute painful neuropathies are very interesting. I'm pretty sure that most of you may have heard of these before. I will go in detail later about these. So this is the same slide, rather in a simplified form. We will classify the diabetic neuropathies in two types: the generalized symmetric polyneuropathy and the focal and multifocal neuropathies. And I will go through them one by one. So first of all, generalized symmetric polyneuropathies. This is perhaps the most common type of the diabetic neuropathy that we see in our patients, and some physicians use it synonymous with the diabetic neuropathy, but this is not the case. About three-fourths of the patients, of the diabetic patient, they tend to develop this distal symmetrical polyneuropathy. It has multiple forms. Uh, the most common is this sensory predominant diabetic neuropathy. This it usually develops in length dependent pattern. From length dependent, we mean that the long nerves, they tend to be involved first, and later the shorter nerves tend to get involved. So the symptoms will typically start in the lower limbs, and then with the passage of time, with the worsening disease, they tend to spread upwards to the upper limbs, and then with the sensation in very advanced cases, the sensations become impaired over your anterior chest and the abdomen as well. So it rather producing a wedge-shaped area of sensory loss. Uh, if we classify this symmetric polyneuropathy, we can broadly classify into two types: this large fiber neuropathy and the small fiber variant. So large fiber variant, as we all know, the dorsal columns, they mainly convey this joint position and vibration sense. So this patient typically they will present with painless paresthesias, some tingling, some tingling or feeling of numbness, and when you examine them, they have impaired joint and vibration senses. And this is the most perhaps the most common variety we see in our clinical practice as well, with the patients having absent ankle and lateral knee reflexes as well. And when you examine them, vibration and joint position sense are absent. So as joint and vibration senses are affected early, so with the progression of the disease, later the patient tend to develop ataxia. This is a sensory ataxia, not a cerebellar ataxia. Now, the small fiber neuropathy is small fibers we remember from our anatomy, spinothalamic tract. So, for the spinal thalamic tract, pain and temperature sensations will be impaired here. So there are two types of sensory phenomena that we see in such patients, either positive sensory phenomena or negative sensory phenomena. So the positive, the patient will complain of either burning or tingling or stinging pain, and the negative will be allodynia, and I will explain these pain categories later. And spontaneous shooting pains, the patient presents with painful symptoms. So when you examine them, and the joint position and vibration senses will be normal, but the pain and temperature senses, they are absent on examination. So these are the other variants that I told you before. These are normally, but people think there are only two types of sensory neuropathy. Either he will have numbness or either he will complain of pain. But there are some other specific types of these neuropathies as well. This is an important variant. Then we need to understand these things. The first of all is the impaired glucose tolerance neuropathy. Most people, they think that only someone with diabetes, he will have diabetic neuropathy, but the answer is no, because it has been studied very in detail and in large number of patients that impaired glucose tolerance, such patients tend to develop diabetic neuropathy even before the progression of the disease, before the clinical diagnosis of the disease. So whenever you see a patient who is clinically or on neurophysiological testing, he is having some peripheral neuropathy, and you are thinking, okay, maybe it is diabetes. When you check sugar, the the levels are normal. So always go for oral glucose tolerance test, because impaired glucose tolerance, it does cause neuropathy even before the onset of the true diabetes. And the point to remember here is that if you control the glucose aggressively at this stage, and prevent the overt development of diabetes mellitus, the neuropathy tend to settle in such patients, and they tend to get better over the period of time with the better glycemic control. Now, this is a very interesting type of neuropathy that physicians usually see. That a patient come to them, they come he presents as very poorly controlled diabetes. When the physician starts him on insulin and medications to provide a better diabetic control, glucose is normal, but the patient will present and complain that I have very severe pain now. This is usually small fiber neuropathies, and the burning pain and paresthesia are the presenting symptoms, and usually they are very distressing for the patient. The pathogenesis, if we just discuss briefly here, is that before the local milieu of that cell was that it was living in a hyperglycemic environment. So suddenly, when the glycemic control is attained, it tend to affect the local blood flow variations and development of like we see reperfusion injury in the myocardium and the other tissue. So it cause of somewhat simulates those, and it causes local nerve fiber damage, and this precipitates a neuropathy. But all we have to do here is to just to reassure the patient, because this tend to settle over 3 to 6 months time. Another variant of the generalized neuropathy is this hyperglycemic neuropathy. It usually presents in the newly diagnosed patients, and it is somewhat same as that of the treatment-induced neuropathy, that the patient, when they suddenly develop hyperglycemia, all of us, this body is not used to that in a new environment. There is an increased production of reactive oxygen species, and they cause local neuronal damage, resulting in the precipitation of the neuropathy. Case here is that when you control the when you control the diabetes, there's good RBS control, symptom tend to settle over the period of time. Now, this is rather a extreme end of the spectrum of the diabetic neuropathies. The patient, they present with acute and painful neuropathy and associated with severe weight loss, depression, and insomnia, and they tend to have the autonomic involvement as well. For example, this men, they usually present with impotence. This is more common because of the poor glycemic control in the patient. The Such patients should be reassured because tend to settle over the period of time, and good glycemic control should be the target in such patients. Now, neuropathic arthropathy. I will come to this later as well as in the pictures. Is the now, as we all know, there are two type of diabetic neuropathies: large fiber and small fiber. So, with the progressive sensory loss, what happens is that when there's loss of joint position sense, loss of vibration sense, so the patient, they become more prone to injuries, and this progressive damage to the for local trauma to the feet, it usually affect small joints more as compared to the large joints. In syphilis, what we see in arthropathy, with the infectious arthropathy, large joints are more involved. But in diabetic neuropathic arthropathy, is the because of the impairment of the joint in position senses and impaired autonomic flow to the autonomic local autonomic blood flow, these small joints of the feet are more involved. They lead to trophic changes. I will show these to you in the slide later, and they called foot deformities, ulceration, and ultimately loss of the limb. Now, another variant of the generalized neuropathy is the autonomic neuropathy. The autonomic neuropathy, it is very important to recognize because this can be life-threatening to the patient. And an important point here is the small fiber neuropathy. It tend to correlate with the autonomic neuropathy. If the patient is having showing signs of severe small fiber neuropathy, so autonomic neuropathy, the clinical sorry, the clinical this clinician should always be thinking about this thing, that the patient may have autonomic involvement as well, because this small fiber neuropathy is getting more severe with the passage of time. Now, this autonomic involvement, the most important thing here is with the cardiac involvement. The first important sign is the increased basal heart rate. Patient tend to have this tachycardia and abnormal sinus rhythm with the sinus variation with the respiration. So this is usually the first sign in the patients in the myocardium, and the risk of silent myocardial infarctions are very high in such patients. Then, if we move to the GI, there is esophageal dysfunction and gastroparesis in intestine. Usually, the patient tend to develop diarrhea. This is because of the impaired small intestinal motility. And the important thing about diabetic diarrhea is it tend to happen more at night. It is very explosive because the small intestine is involved, so the water absorption is very there's increased water secretion, so it's explosive diarrhea, and it usually happens at night. But the patients can also present with very severe constipation, and the constipation is perhaps more common in diabetic autonomic neuropathy uh, compared with the diarrhea. And as we all know, other urogenital involvement, we have patient tend to present with the urinary incontinence or atonic bladder, and the male can usually present with the impotence and retrograde ejaculation. Moving on to our next part, that is the focal and asymmetric neuropathies. Now, the focal neuropathies can be classified into limb mononeuropathies, compressive neuropathies, the mononeurtis multiplex in the radiculopathic pattern that we usually see in the diabetic patients. So in mononeuropathies, actually there are two mechanisms. First is there is impaired blood flow to that nerve because of the compromise. I will come to the explaining the pathogenesis later. So there's abrupt onset, impaired blood flow causes nerve infarction, and there's abrupt sudden onset weakness in the distribution of the nerve. This is a first mechanism that is usually implicated in the mononeuropathies. But perhaps a more common thing here is the intrapid neuropathy, the nerve that is already compromised because of hyperglycemia, because of poor blood flow, because of the reactive oxygen species induced damage, and they are more prone to entrapment neuropathy. So the most commonly these patients present with the limb neuropathy. There's a higher incidence of carpal tunnel syndromes, there's higher incidence of ulnar neuropathy, and there is a higher incidence of peroneal neuropathies. The primary lesion here is a compromised blood flow is this axonal degeneration. Uh, in cranial neuropathies, it is a second type. The most common of the cranial neuropathies in such patient is a third nerve palsy, and the hallmark of this third nerve palsy is a pupillary sparing palsy, and because the infarcted tissue nerve stem is the muscle controlling fibers that we all know in the third nerve, they are in the concentrated in the center, and the fibers for the pupil, they are uh, at the periphery of the nerve. So when in the compressive neuropathies, the pupil is involved early, but in the ischemic neuropathies, the nerve is the muscles are weak, but the pupil will be spared. It is the most common variety. Other is important is the Bell's palsy. This is the seven nerve palsy. Patient, sorry.
No, no, please carry on. Carry on. Waleed,
Yes, yes.
mute कर दो
And in
ताकि वो
the other most important nerve usually in the order of frequency is fourth nerve that we even in my clinical practice I seen patients who have presented with sudden onset non-traumatic fourth nerve palsy, sixth nerve palsy, and the seventh nerve the Bell's palsy. They are also very common in the diabetic patients, and even in our clinical practice as well. I have diagnosed 2 3 patients who have presented with diabetes, Bell's palsy, and later on testing we found that they have diabetes as well. Now, this is a very interesting thing, the truncal neuropathy. I hope that most of you have seen patients with symptoms of truncal neuropathy. I just want to share a case just to further your interest. I have recently seen one patient. She was referred to me from my nephrologist friend, and she had 1 year history of very severe right flank pain. And on examination, she had some local hyperesthesia to in that region as well. So she had been going to nephrologist and urologist for about 1 year, and they did CT scan, even CT abdomen, ultrasound abdomen, everything, and it came out to be normal. So when she came to me, I took history from her, and one thing that clicked my mind was this hyperesthesia in the distribution of T10, T11 nerve root. So I was thinking maybe she is having truncal neuropathy of the diabetes. There was no history of varicella zoster. So I started her on venlafaxine because she had comorbid depression as well. She didn't tolerate duloxetine, so I gave her venlafaxine, and she showed very good response. And in after 3 4 weeks, when she came back, she was very happy that her pain has reduced to almost uh, 20 30% of to the baseline. So it was more than half of the more than half of the pain had gone by that time with the medications. So I just titrated the dose and told her to continue with this. So this is just for your interest. Just wanted to share one case that patient can present with such a non-specific pain, but this pain is usually very intense and is dysesthesia, and usually it is in the region of chest and abdomen. The first thing usually come is maybe it is herpes zoster, but when you ask the patient, there is no such history. This pain, the etiology of this neuropathy is usually ischemic. There's ischemic nerve infarction, and it is very distressful to the patient because normally this area is covered with clothes. So there is hyperesthesia, and it is very unpleasant for the patient when the clothing can come in contact with this patient, with this skin. And also, most of the investigative workup when the physicians do, it come up to be normal. So please, whenever you see such patient, just keep this thing in mind that it may the patient may present with diabetic neuropathy in such a manner. And the important and the good point about these patients is some of the patients they usually show good and spontaneous resolution after 4 to 6 months of onset of the pain. Now, as I told you before, the diabetic neuropathy, the mononeuropathies are usually ischemic in nature. So, where this ischemia can occur spontaneously in multiple nerves, different nerves. So, the patient can present as a multiple mononeuropathic pattern. So, ischemic infarction one nerve, after some time ischemic infarction in another nerve. But you have to keep one important point here that we have to rule connective tissue disorder in such patients. Don't attribute it to diabetes, especially diabetic patient with mononeuritis multiplex pattern. We cannot just assume that this is due to diabetes. We have to rule out other secondary causes in such patients. Now, this is another very discussed thing in the diabetes, but the cases are not usually go unnoticed. This is a diabetic amyotrophy or diabetic polyradiculopathy. It is also known as Garland syndrome, after the physician or scientist who described it first. Again, I will just share a quick brief case for to draw your interest. I recently discharged one patient from our neurology unit as well. She had presented to me with severe pain in her thigh. This pain was very severe and unbearable for the patient. She was literally crying at that time, and it was associated with the tenderness in the thigh as well. Examination other than tenderness also revealed mild weakness of her hip flexors and knee extensors. There was some weakness and asymmetry of the knee reflexes on both sides. Lumbosacral MRI was normal, although there was radiculopathic changes, but not at the level she was describing. It was mostly involving lower nerve roots. The glycemic control suggested by HbA1c was also poor. And another thing was that her ultrasound abdomen, everything was normal, though there was no SWAS abscess or anything like that. So my clinical diagnosis in this patient was diabetic amyotrophy. I didn't do NCA-CMG because this was just 4 or 5 days history. So we started her on solumedrol in 1 gram dose. We usually give this is in a weekly dose for about 4 to 6 weeks to the patients, and she did show good recovery with steroids. So if the pain, if we stay for long in such patients and it is not diagnosed, what happens is usually tend to recede, but the patient tend to develop weakness of the quadriceps, and this is usually due to the involvement of the lumbar plexus. So patients can also present with the involvement in the thoracic plexus and sometimes in the cervical region as well. And the important thing about this polyradiculopathy or amyotrophy is that its recovery is very slow. Unlike other, where I explained before, it's usually 3 to 6 months, the patient tend to get better, but here it may take up to 2 years for full recovery in such patients. This is a slide that should have been in the beginning, but I forgot to put it there. So this brief overview to how the painful neuropathy can present. Patient can complain of burning. They can complain of tingling, electric shock like pain. It is very distressing for the patient. Just uncomfortable numbness and the stabbing pains. So this is just as I had mentioned in my previous slide, the positive symptoms that may present and the negative symptoms. So the positive symptoms, they are very distressing for the patient. Usually there's spontaneous pain. There's allodynia. I will explain these in the next slide. There's hyperalgesia, dysesthesia, and paresthesias. And the negative symptoms, they are usually hyposthesia. There is anesthesia, hypoalgesia, or analgesia. I will explain these in my next slide. So what is allodynia? Allodynia mean pain caused by an action that is not usually painful. For example, if you gently touch someone's hand and he is complaining of pain. So this is allodynia. Should not be normally painful, but here it is painful. Hyperesthesia mean that excessively painful reaction in contact with everyday object, as I explained with that in the diabetic thoracic radiculopathy patient. Their even clothes are very irritable for the patient. So this is hyperesthesia. Hyperalgesia mean excessively painful response that normally causes mild pain, but here the pain is exaggerated. Hyperpathy mean you have removed the stimulus, but still the patient is complaining of the pain. And the paresthesia, dysthesias mean abnormal, unpleasant sensation, which are felt as intense tingling or pins and needles. So this is a effect of the diabetic neuropathy. There is tissue damage. You can see minor trauma here, and over the period of time, because of the repeated trauma, the abnormal local blood supply and the abnormal sensations the sensory loss. The patient tend to develop clatos, small fiber neuropathy. There's muscle loss in between the metatarsal bones, so they develop clawing. There's callus formations and superficial ulceration as well. Here again, this callus formation, skin thickening with the ulceration. And again, this is somewhat similar slide. So, what is the pathogenesis of diabetic neuropathy? Actually, the pathogenesis is b- due to two factors. First is the hyperglycemia, and the other is the impaired blood flow. As we all know, diabetes causes vasculopathy. So, the progressive vasculopathy, which impairs the endoneural vascular resistance, it causes a reduced blood flow and it leads to ischemia of the nerves. The other somewhat complicated pathogenic mechanism is the hyperglycemia. Hyperglycemia itself, it causes a depletion of the myoinositol in the nerves and it causes the activation of the protein kinase C. This protein kinase C, it is toxic to the nerves and it causes impaired Schwann cell function and the axonal transport. As I had mentioned the beginning of my slide, कि लंबे लोगों में diabetic neuropathy ज़्यादा जल्दी develop होती है because the axons they are longer. Spinal cord से लेके feet तक distance ज़्यादा हो गया तो axonal longer. The axonal transport is affected here. So this protein kinase is actually the main culprit here. This causes the impaired axonal transport. It damages the Schwann cells, so it leads to the progression of the neuropathy. Another, and as you all know this very well, other proposed mechanisms are this polyol pathway. This will lead to the formation of abnormal sorbitol and fructose in the nerves. This causes local damage to the nerves. And the third and more important is the reactive oxygen species, which causes local damage. So this is just a brief overview of the same things. This polyol pathway lead to increase sorbitol and it is locally toxic to the nerves. This advanced glycolation end product, they need to increase formation of the free radicals, which causes nerve damage. The oxidative stress also do the same things. And there's increased local inflammation because of this protein kinase C and reactive oxygen species. So they all these factors contribute in, in a synergistic way and contribute to the progression of the neuropathy in diabetics. Now, the important thing is how to diagnose the diabetic neuropathy. We every day we see patients in our clinical practice, and we just assume that okay, he's complaining of numbness, so maybe he's having diabetic neuropathy. But there is a proper questionnaire for that. We use first of all, I will mention these in detail. Diabetic neuropathy 4 questionnaire that you can use in your everyday practice. Clinical history is very important about the diabetic control, the symptoms, the onset, the progression of the symptoms. Just 1 minute, please. I have one call. I will just take it briefly. It is important from the hospital. Yes, in the patients. Other is the quantitative sensitivity testing. If there's some confusion, we can do skin biopsy. This is the intraepidermal nerve fiber density वे इसमें हम check करते हैं, and then the corneal confocal microscopy. This is rather a latest more advanced in which with a high power scope we check the cornea and the nerve fiber network in the cornea is assessed, and there's a specific grading for this and it helps to quantify this diabetic neuropathy in the nerve fiber loss, yes. So Neuropathic screening tools, there are various scales. This is Lance scales. This is Diabetic Neuropathy Questionnaire 4, and then Neuropathic Pain Questionnaire, Pain Detect, ID Pain. There are multiple scales. You can use whatever you want based on your own easy accessibility, based on your own accessibility and ease of
क्या
use.
लग गया 1 बजे तक लेक्चर
So the sensitivity, if we check, so these two scales are rather very good. This interview and physical test in large scales, we ask 5 items, and there are 2 clinical exam items. The sensitivity is about 82 to 91%, and the specificity about 94%. Diabetic neuropathy questionnaire 4, there are 7 symptoms and 3 clinical exam items, and here the sensitivity is about 83%, and the specificity is about 90%. So this is just uh, sample large scale, and there's a pain questionnaire. You can see detail later and then there is testing. What you do is you ask the patient 1, 2, 3, 4, 5 questions, and then there is examination items. You score those, and total score is maximum is 24. If the score is less than 12, the patient is unlikely to have diabetic neuropathy as a cause of his pains or her pains. And if the score is more than 12, then the diabetic painful neuropathy is perhaps the underlying mechanism for the patient's neuropathic pain. Then other is through this is last scale. Then other way that is easy is to just to interview the patient, and uh, with these 4 questionnaires, I will tell you. First is does the patient have any of the following characteristics? Is it burning pain? Are the feet feel cold? Are they electric shock like pain? Or if the pain is related with one of the more of the following, is it tingling, pains, numbness, or itching? Is the pain located in the area where physical examination may reveal one of the more of the following? There is hyposthesia or hyposthesia to touch and pinprick. And last is the painful area can be pain by cause, or this is a hyperesthesia or brushing that I explained previously. So you ask the patient, and if they positive yes score is 1 and no score is 0. So if this is basically the DN4 score that I told you before. So if the score is more than 4, the patient is having neuropathic pain. If the score is less than 4, the uh, the probability is less. So this how to quantify diabetic neuropathy, how to grade it. So this is a diabetic neuropathy severity scale. It is graded as 1 to 3. Uh, 0 is no neuropathy. 1 is subclinical peripheral neuropathy, that you just examined the patient, he didn't have any symptoms, but when you examined it, there was some evidence of the neuropathy. 2A is clinical diabetic neuropathy with symptoms, and 2B is a clinical diabetic neuropathy uh, with negative symptoms. And the 3 is the advanced stage or the late stage. So how to treat such patients? As you all know, the cornerstone of the treatment for diabetic neuropathy is the good glycemic control. Optimal glycemic control is the only way we can prevent the progression of diabetes in the long term. There are certain trials. First is the ECART trial. Uh, it showed that diabetic neuropathy was significantly reduced with intensive control. But ultimately, when the patient was switched to this regular therapy, the incidence increased again. Advanced trial uh, was for new or worsening neuropathy, and the secondary outcome was that it did not seem to affect the intensive blood glucose control, affected the development of neuropathy. But in diabetes case control trial, uh, the intensive blood glucose did prevent the development of diabetic neuropathy in the long term. So the optimal glucose level should always be the target for the patient, and it not only prevents the other systemic complications, but it also prevents the development of diabetic neuropathy. Now, when we see diabetic patients with neuropathic pain, usually this is the more important thing. So there should be 2 goals in the patient for treatment. First is to achieve pain control. And we should always have realistic targets. More than 50% or about 50% pain control should be our target, because it is usually impossible to achieve total remission of the pain. And the second is to improve their quality of life, their mood, their sleep, and the function. Now, these are the various, this is just a chart which shows the various level of intervention that we can do in the patient. First is the psychological approach in the patient. The second is use of the topical medications. The third is oral medications. Fourth is the injection use. And fifth is the interventional techniques. These include TENS, this tissue, this transepidermal nerve stimulation, acupuncture. These are the more invasive techniques, but we always start with the CBT. We counsel the patient about meditation, biofeedback, and relaxation therapy. Physical rehab is very important. And now this, and then the use of medications. Now this is not the busy slide, but this is very important. It is showing various medications that we can use for treatment of the diabetic neuropathic pain and the mechanism of action. Now in the first of all, sorry. The first thing that we use is the topical medications. Capsaicin is very important. It causes decreases the local peripheral, local nerve sensitization. Local anesthetics, for example, 3% lignocaine and tricyclic antidepressant, they also act locally as well, but they also affect in the CNS. They prevent the nerve ectopic discharges and control the pain. Now, centrally acting nerves include SNRIs, tricyclic antidepressants, and the opiates. And then we have GABA ligands. I will discuss these in detail in later slides. Now, first of all, the more commonly used pregabalin and the gabapentin, they are basically they act on the calcium channels. What happens usually is when there is nerve injury, it is hypothesized that it causes increased formation of the calcium channels in the periphery of the nerves. These calcium channels are later transported to the nerve terminals in the dorsal horn of the spinal cord, and this increased number of the calcium channel, they causes increased calcium influx, increased neuronal excitability, and increased pain sensitivity in the patient. So, how you reduce the pain? Then you use calcium channel blockers, and these calcium channel blockers include gabapentin and pregabalin. They act as ligands at alpha 2 delta ligands linked. They act on the alpha 2 delta ligand linked calcium channels, and they reduce this peripheral nerve excitability and reduce the neuropathic pain. Other drugs that we use are SNRIs. The SNRIs, they have two effect. They are centrally acting drugs. They in the brain they cause a reduced perception of the pain. They reduce the ascending input, and they prevent the ectopic discharges in the nerve. And the pain transmission is also reduced. And SNRIs that we normally use are duloxetine and venlafaxine. They have dual effect in the patient because the patient they usually have comorbid depression as well. So they not only treat depression, but they also control the peripheral neuropathic pain. So this is as per the American Academy of Neurology, the first line should always be pregabalin, and the second line drugs include gabapentin, duloxetine, amitriptyline, opioids, and tramadol. But here then you have to see for the comorbidities of the patient, because diabetic patients they usually don't have a single diabetes. So they have
कुछ ही पाना फ्राई पैन दिखाना
so diabetic.
जो पाक
Everyone mute yourself, please.
So diabetic patients, they usually don't have a single diabetes only. They tend to have multiple comorbidities. So then you have to tailor your approach as per the comorbidities of the patient. Tramadol, I personally don't use in my patients because long term it tend to cause dependence in the patients, and also it has effects interactions with the SSRIs with the risk of development of serotonin syndrome. So we don't usually use it in opioids in our daily practice. Pregabalin, as we all know, it causes fluid retention. So the patients with ischemic heart disease or ischemic cardiomyopathy, pregabalin is perhaps not a good choice. And the most safe in patient with ischemic heart disease is gabapentin. It has the lowest incidence of fluid retention. So in patient with ischemic cardiomyopathy with low ejection fraction but diabetic neuropathic pain, gabapentin is perhaps better choice. Again, if they have comorbid depression, obviously, then you should opt for duloxetine. If such symptoms are not there and there is a bladder involvement, for example, there is overflow incontinence or urgency or more some sleep issues, so amitriptyline, a tricycline antidepressant, is a better choice. So you have to tailor your drugs choice on the base of the patient case scenario. You have to consider comorbidities, you have to consider their ease of use and long-term complications. So these are the different pharmacological treatment for neuropathic pain. There's a chart that we can use: gabapentin, pregabalin, duloxetine, venlafaxine, and tricyclic antidepressants. And then these are in the topical second or third line, where these medications don't provide that much benefit to the patient. You can add opioids or tramadol. Capsaicin locally can be used in opioids. And then the surgery, this is transelectric nerve stimulation, or we can use acupuncture or even intraspinal anesthesia as well for the patient for the control of the pain. So this is just a flow chart. Sorry. So this is usually the first step should be to initiate a first line treatment. Start with gabapentin or pregabalin or venlafaxine, considering the comorbidities and the age of the patient. Tricyclics are usually the second line, and topical lidocaine or capsaicin can be used. If for example, you started the patient on, let's say, pregabalin in 50 mg BD dose, you titrated it upward the maximum dose of 1 to 300 is 150 mg BD. You stopped at 200 mg BD and the pain is not yet controlled, the patient is still very distressed, then you can add from one of these, duloxetine and venlafaxine. You can add to this. I will obviously not add gabapentin to pregabalin because both have same mechanism of action. So what we do is we add SNRI to alpha this calcium ligands, and usually they control the pain very well. If both of these fail, then what we do is we use a third medication. For example, SSRIs, carbamazepine, lamotrigine, topiramate, multiple choices. Then you can use from anti-epileptic group, you can use from antidepressant group as well. So these are the American Diabetic Association guidelines. So pain management, consider either pregabalin or duloxetine as initial approach for the symptomatic treatment. And what is the recommendation? Tight glucose control, targeting near normal glycemia in the patients with type 1 diabetes. And the type 2 is with who have more advanced disease. They have more risk factors. Obviously, most of them are in the old age group. So intensive glucose control is only modestly effective because there are some other factors playing their role as well. So lifestyle intervention and medication both are used in such patients. And for the autonomic neuropathy, what we do is for bladder control, voluntary urination, intermittent catheterization can be used. For retrograde ejaculation, antihistamines are used. For erectile dysfunction, sildenafil or tadalafil is used. And for dyspareunia, lubricants or estrogen creams are used. For gastroparesis, obviously we use prokinetics. And for enteropathy, if the patient is having diabetic diarrhea, loperamide. If there's bacterial overgrowth, you will give antibiotics. If there's constipation, which I told you before is more common, stool softness and dietary fiber is used. For patient with cardiac autonomic involvement and who usually present with the postural hypotension, what you tell them is usually we teach them to lie in the bed with their head and elevated. What it does is the brain senses that as a patient is euvolumic, low volumic, hypovolumic, so there's less water loss, free water loss while the patient is fine, especially at night. And so the early morning hypertension can be avoided in such patients. If there's still troublesome hypertension, then we can use midodrine or fludrocortisone in such patients. So if the patient is presented to you is diabetic symmetric polyneuropathy, if you are not sure, refer to the neurophysician or pain clinic. If you are sure, then assess the comorbidities, as I told you before, because patients they usually have multiple comorbidities. They are using multiple drugs, so you have to be aware of the possible interaction between the drugs. Same simple example is patient is using pregabalin already, and his pain is not controlled. So, and he has ischemic heart disease with a low ejection fraction. So you will not use venlafaxine in such case, because venlafaxine causes very troublesome tachycardia. He is already using pregabalin, which is worsening his heart failure because it causes fluid retention. So you slowly taper down pregabalin. You use duloxetine or gabapentin, and you reassess the patient, and then you try for topical treatments. If the pain is still not controlled, then you can move to more aggressive or invasive approaches. So this is somewhat same as I showed in the previous slide. This is step one. You select from these. If this is not improving, then you add from pregabalin or duloxetine to one another, or you can add a tricyclic antidepressant as well. If they have no meaningful effect for the patient, you combine them together. If still not, then you can add short-term opioid anti-epileptic drug, for example, carbamazepine or lamotrigine for neuropathic pain. This is the same thing I told you for cardiovascular autonomic neuropathy. Discontinue any aggravating drug. For example, old patients you usually have BPH. If you are using tamsulosin, they will have more chance of postural hypertension. So we try to switch it to, for example, sildosucin that has a lower chance of developing postural hypertension. Still, there is a chance, but lower as compared to tamsulosin. We tell the patient to change the posture, especially at night, elevate the head end of the rays. We encourage them to drink more water. And still, if all these things are not helpful, then mineralocorticoid, fluorocortisone, or midodrine or increased salt intake, if the patient is not having cardiomyopathy, can help with the patients. This is just a patient who is just complaining there's no neuropathic pain. The patient is having neuropathic pain with small large fiber neuropathy. So is there any way we can reverse it? To date, there is no single agent that has been proven 100% effective in the reversing of the diabetic neuropathy, because as I told you, in the pathogenesis usually there is nerve damage, there's fiber loss, so it cannot be recovered. But there are certain agents who have shown promising results in study. One of those agents is alpha lipoic acid. Usually we use it in dose of 300 to 600 mg per day. In Pakistan, it is available as 300 mg preparation. We use it in our patient, and usually with pregabalin, it does help the patient with their neuropathic pain. And studies have shown that it helps neuropathic symptoms in the patient as well. Alpha linoleic acid is also another agent that has shown benefit. Vascular endothelial growth factors, they were tried, but they didn't show any promising results. As I told you, the most important thing is the exercise, the diabetic control that can help the diabetic neuropathy, prevention of diabetic neuropathy. And the most, I should have, I intentionally shared this slide at the end, that always keep one thing in mind. It is diabetic neuropathy is the presence of symptoms and signs of peripheral nerve dysfunction in patient with diabetes after you exclude other causes. Whenever you are seeing a patient with diabetes who has polyneuropathy, always exclude other causes, because there are myriad of other DDs that can present clinically as diabetic neuropathy. For example, uremic neuropathy, for example, B12 deficiency, for example, alcoholic neuropathy, and most importantly, CIDP. So, conclusion of my presentation is the most common is a common diabetic microvascular complication. Diabetic neuropathy can be caused by etiologies other than diabetes mellitus and diabetics. Distal symmetric polyneuropathy is the most prevalent form. And once it is established, the existing damage is largely irreversible. And many doctors incorrectly assume that the term diabetic neuropathy is synonymous with the distal symmetrical polyneuropathy, but there are other variants that I told you in my presentation. And the tight control of the sugar is a cornerstone of the therapy. Thank you so much for your time. I think I did clarify some concepts about diabetic neuropathy. If you have any questions, you can ask me, please.
Thank you very much. It was an excellent presentation, Dr. Farooq. Very elaborative. I wish we would have more time. Now, there are some questions in the chat box, and anyone who wants to ask a question can raise the hands. But before that,
I
Dr.
will check the chat.
Savitri from Dr. Savitri from Sri Lanka is here. Sri Lanka is suffering from the worst floods. We request everyone to observe 30 seconds silence and to pray for the effective so that their life gets easy. So I just start the timer and everyone silence for 30 seconds, please. Thank you, everyone. Dr. Savitri, we are standing in solidarity and in sympathy with you. And we wish and we pray and we have all support for the blood effectives. Now, there is no question in the raise hand.
एक question है. There's one question.
Yes,
What about
there are
methylcobalamin
questions.
in neuropathy?
Yes, there are questions in the chat box. So, first question is, what about
Yes, there is one
methylcobalamin
question.
in neuropathy?
Actually, I have studied about this because even in our practice as well, we see most of the physicians writing methylcobal to the patient, and they do report of benefit, symptomatic benefit. And actually, in high doses, for example, 500 microgram or 1 gram dose, it is usually prescribed here. I have studied about this, and it is mentioned there in the data that it act as a neuroprotective agent and in a local neurotropic factor, and it does help the patient with the pain, but long term should be avoided because unless someone has a clinical deficiency, but overall we can give it to the patient who are unaffording other
So,
expensive medications.
can it be given without measuring serum B12 levels or patients who are
Yes,
having normal
yes,
serum
because
B12
we are
levels?
we are actually we are not treating sorry, B12 deficiency here. We are just giving a planning to give a neurotrophic factor to the patient. So yes, we can give it.
Right. Second is that you talked of tramadol having interaction with the SSRIs and they
SSRI.
may cause serotonin syndrome. Does it occur same with the SNRIs like duloxetine? Serotonin syndrome
Yes,
can occur with
same. Yes, same.
SNRIs
Because
also?
yes, because tramadol has multiple mechanism of actions. It acted opioid receptors. It interacts with the inhibits serotonin release. Sorry, reuptake. It inhibits norepinephrine reuptake. So it does have effect on those. So should better be
Right.
avoided in patients. Even if you are planning to give it, better give it in lowest possible dose.
Right. Third question I received that you talked of so many products. Is there anyone which can cause regeneration of the nerves, peripheral nerves, if they are damaged?
I did mention it. Alpha lipoic acid. It does not cause regeneration, but it help with the resolution of neuropathic symptoms over the period of time. It tend to reverse some of the changes in the nerves peripherally in the local metabolic environment of the nerves, and can slow down the ongoing damage. This alpha lipoic acid is available in Pakistan. I know only one brand, ALA1, ALAONE, ALA1, because it only I have seen only this one has 300 mg of alpha lipoic acid. Rest of there are other marketed products as well, but the alpha lipoic acid concentration in those is low. But the studies have been in the studies which were alpha lipoic acid was studied. Most of the dose in use in those studies was 300 to 600 mg per day. So
Yes.
whenever you are giving it, better give it in a proper dose.
Yes, it is also contained in the product called Relone, probably by Surly Company, which has alpha lipoic acid and
Elon has
thycobalamine and pyridoxine and others
it
also.
has less. Yes, yes, yes. But
Uh,
it has a lesser quantity. This is what I was
yes, yes,
mentioning.
yes,
It has, I think, only 50 30
right.
mg of alpha lipoic
Another
acid.
question that I have received is that all these products for neuropathy, you mentioned specifically for diabetic neuropathy, are they equally effective in other causes of neuropathy? Of course,
Yes, they do help
there's a
in other
definitely
painful
clinical
neuropathies.
cause. Other causes of
Yes, yes,
neuropathy
they do
like
help
spinal
in.
stenosis, etc.
Yes, yes, it do help in those.
They help. right?
Basically, they are painful.
Right. I am receiving some more questions. Dr. Rafiq wants to talk, but we shall give you time. The question is that how long we can give SNRIs? This is.
It depends on the patient and their response. For example, if depression, you will find if 6 months to 1 year, or even after remission can be there's cut. I have not read cut guide on those. I will go through come back to you, inshallah. That what are the usual duration? But normally we give it for
Right.
6 months to 1 year.
Right. I do not have any written questions now. Dr. Rafiq wants to talk. Dr. Rafiq, please, you can start. You talk.
Assalamu alaikum. Are you hearing me?
Yes.
अच्छा
Yes,
मेरी
we
एक
can hear you.
मैं पहले तो जो NSRI हैं थोड़ा सा डिटेल में साकिब साहब से पूछूंगा कि ये NSRI के प्रोडक्ट्स कौन कौन सी अवेलेबल हैं और किस डोज में देनी है। सवाल तो मेरा ये है नंबर 1। और नंबर 2 ये है कि अमूमन जो ये पेशेंट्स होते हैं डायबिटीज़ के, और ये जितनी ड्रग्स का जिक्र किया है एक्चुअली उन्हें हाइपरटेंशन भी होता है, कार्डियोवैस्कुलर डिजीज़ भी होती है, डायबिटीज़ भी होती है और उसके साथ दूसरी कॉम्प्लिकेशंस भी होती हैं।
Yeah.
इन्होंने जिक्र किया एंटी डिप्रेसेंट्स का, वो अमूमन मोनो अमाइनो ऑक्सीडेज इनहिबिटर्स होती हैं और बहुत सारी ड्रग्स के साथ उनका इंटरेक्शन होता है। तो एक क्वेश्चन तो मेरा NSRI है कि वो डिटेल में
रफीक साहब, एक मैं आपको इंटरप्ट करता हूँ। डॉक्टर फारूक, आप अपनी स्क्रीन को अनशेयर कर दें ताकि हम सब एक दूसरे को व्यू कर सकें। प्लीज अनशेयर स्क्रीन। जी डॉक्टर
असल
रफीक,
में
यू कंटिन्यू प्लीज।
आई सॉरी आई एम इन माय बेडरूम सो आई
नहीं नहीं
कांट।
नहीं नहीं, कैमरा ऑन ना करें। मैं सिर्फ फारूक साहब को कह रहा हूँ कि अपनी स्क्रीन को शेयर करना बंद कर दें ताकि हम सारे जो हैं वो स्क्रीन पे सामने आ जाए मेरे। थैंक यू। राइट।
तो
चलिए
मेरे
रफीक साहब, प्लीज कंटिन्यू।
अब मेरे चलें दो को, पहला क्वेश्चन तो मेरा ये है कि ये सारे जितने पेशेंट्स होते हैं अमूमन, मैं इंक्लूडिंग माई सेल्फ, आई एम डायबिटिक, आई एम हाइपरटेंसिव, कार्डियक बाईपास सर्जरी, देन स्टेंट इन द बाईपास ग्राफ्ट्स एटसेट्रा। तो ये एक तो कैल्शियम चैनल ब्लॉकर्स की बात मैं कर रहा हूँ, अमूमन ये अमलोडोपिन ले रहे होते हैं पेशेंट नंबर 1। ये भी कैल्शियम चैनल ब्लॉकर्स हैं जो इन्होंने जिक्र किया, गाबापेंटिन और प्रीगैबलिन का। NSRIs कौन कौन सी हैं, कौन से डोज में इंपॉर्टेंट है, मतलब ये सारी ड्रग्स ये देख इस पेशेंट के सिनारियो में देखें कि वो डायबिटिक भी है, उसे कार्डियक प्रॉब्लम भी है, वो हाइपरटेंसिव भी है और उसे डायबिटिक न्यूरोपैथी है। तो बेस्ट मेडिसिन ऐसे पेशेंट्स के लिए कौन सी होगी? और ट्राईसाइक्लिक एंटी डिप्रेसेंट्स के अमूमन बहुत ज़्यादा साइड इफ़ेक्ट होते हैं और उनके बहुत ज़्यादा ड्रग इंट्रैक्शन होते हैं, तो क्या आप उनको इंडिकेट करेंगे?
जी डॉक्टर फारूक।
NSRI का जिक्र ज़रा तफसील से कीजिएगा। और गैस्ट्रोपेरेसिस के लिए मुझे याद है हमारे ज़माने में हम ऑक्सीटेट्रासाइक्लिन इस्तेमाल करते थे, एरिथ्रोमाइसिन नहीं करते थे। ठीक है जी, क्वेश्चन बहुत हो गए मेरे, 4-5 हो गए।
डॉक्टर फारूक, आर यू कनेक्टेड? Probably he got disconnected. Let us wait. Probably he might be trying to connect again. वलीद, उसको जरा कॉल करके देखें, वो डिस्कनेक्ट हो गए। वलीद, कैन यू हियर मी?
यस सर, मैं करता हूँ।
उन्हें कॉल करके देखें, वो डिस्कनेक्ट हो गए क्योंकि रफीक साहब के कुछ सवाल उन्होंने सुने होंगे, कुछ नहीं सुने होंगे। बहरहाल जस्ट एवरीवन प्लीज होल्ड ऑन टिल द डॉक्टर फारूक जॉइन्स अगेन।
राशिद साहब, उनको ये टेक्स्ट में आप भेज दीजिएगा और फिर ये PMA के पेज पे इनके आंसर्स लगा दीजिएगा, ये ज़्यादा
अच्छा,
बेहतर होगा।
ऐसा करें, आप चैट बॉक्स में क्वेश्चन अगर ये डाल दें तो ये ऑटोमेटिकली रिकॉर्ड हो जाएंगे।
हाँ
ठीक
ना,
है।
मैं
हाँ जी।
हाँ, तो ये है कि फिर उन्हें भेज दीजिएगा टेक्स्ट में, फिर आप
हाँ,
टेक्स्ट में
उन्हें भेज
जवाब।
देंगे, आप चैट बॉक्स में डाल देना तो हम फिर कॉपी पेस्ट करके तो फिर हम उन्हें डाल देंगे।
ठीक है, मैं भी डाल रहा हूँ। ठीक
ठीक है जी।
है।
खत्म हो गया।
सर उनके इंटरनेट का कोई इशू है तो ट्राई कर रहे हैं, कहते हैं अगर मैं ट्राई करता हूँ ज्वाइन हो गया तो मैं आ जाता हूँ,
अच्छा
वरना
अच्छा सर, ऐसा करें कि ऑलरेडी हम टाइम को ओवर यूटिलाइज कर चुके हैं। जिसके भी जो क्वेश्चंस हैं वो चैट बॉक्स में डाल दें, वो ऑटोमेटिकली रिकॉर्ड हो जाएंगे।
सर
एंड रिक्वेस्ट हिम के
सर
बाद में
मेरा
उस
लिंक
पर
नहीं था, अभी आ गया दोबारा।
आ गए। चलो ठीक है। अच्छा डॉक्टर साकिब,
आ गया
वेलकम
जी।
बैक। ये कुछ क्वेश्चंस आए थे और फिर
थैंक
बीच
यू।
में आप डिस्कनेक्ट हो गए। वन क्वेश्चन इज फ्रॉम डॉक्टर रफीक एंड वन इज फ्रॉम डॉक्टर सवित्री. डॉक्टर रफीक इज typing his questions. Meanwhile, please you reply to Dr. Savitri.
सर
How
उनका मैंने
long
क्वेश्चन सुना है।
need
यस सर।
how long do we need
सॉरी
to
सर।
treat patients before any effect is seen in distal symmetrical diabetic peripheral neuropathy? You can read this question in chat box.
सर एक्चुअली
How long
no actually
do we
but I
need to treat?
no actually sir, first I will answer Dr. Rafiqul Hassan question. Actually he
Yes.
was asking that calcium channel blockers, about those calcium channel blocker, this amlodipine and nifedipine, those they are dihydropyridine calcium channel blockers. उनका इसके साथ कोई रिलेशन नहीं है. These are basically anti-epileptic drugs who work in CNS, gabapentin and pregabalin on the calcium F4 delta receptors, and they are only CNS only. They have effect on CNS only. So please keep this in mind. Those are antihypertensive. This is anti-epileptic drug. As far as the SNRIs that are available in Pakistan, duloxetine is available. It is available in dose of 30 mg and 60 mg, usually and 20 mg as well. So usually what we do is we start the patient is 20 mg in the morning dose. After 2 to 3 weeks, we see the response. If the patient is tolerating well, we slowly goes to 30 mg. The maximum dose that we usually we give to the patient is up to 60 mg per day. We continue the drug for 6 weeks and we see if there's a good response. If the patient is showing good response, then we continue with their drug. Or zahir baat hai, the diabetic neuropathy, it is a lifelong thing. The patient has to continue. Same with the venlafaxine. It is available in dose of 37.5 mg and 75 mg in Pakistan, and XR preparation is. So what I do is I start as 37.5 mg half tablet in the morning for say 7 days, 8 days. Then we give the patient full 37.5 mg tablet. We review after 1 month. If the patient is tolerating well, the symptoms are controlled. The maximum dose we can give is 75 mg per day of venlafaxine. For pregabalin, the maximum dose is 300 mg per day, and for gabapentin, you can go up to 600, and maximum dose is even 1200 mg per day. And for diabetic neuropathy, in diabetes with MI and hypertension, if the cardiac function is good, you can give pregabalin, you can give duloxetine, you can give the most safe, as I said, is what I had checked from recent data. Gabapentin, it causes lesser fluid retention than pregabalin, and it does help with the diabetic neuropathy. And venlafaxine, it usually causes tachycardia. So in patients with impaired heart failure, impaired heart function, usually we tend to avoid those. And if someone has heart failure with comorbid depression, so we use sertraline or escitalopram in such scenarios.
Right.
Yes, sir.
Thank you.
ये मेरा एंटी डिप्रेसेंट के हवाले से सवाल था। ये मोनो अमाइनो ऑक्सीडेज इनहिबिटर्स होती हैं और बहुत सारी ड्रग्स के साथ इनका ड्रग इंटरेक्शन होता है। तो आपने ट्राईसाइक्लिक एंटी डिप्रेसेंट बताई हैं, तो ये साइड
Yes, sir.
इफेक्ट्स को कैसे करेंगे?
Side effects, hum usually we give amitriptyline, and as I mentioned, we have to see for the patient's comorbidities. Obviously, someone is using multiple drugs, so I will avoid using tricyclic antidepressant. मैं उन पेशेंट्स को दूंगा जिनको सिर्फ बर्निंग है, फॉर एग्जांपल ये पेरिफेरल पेन है, ही इज कार्डिक, his cardiac function is normal, his renal function is normal, or he is not very old age, he does not have dementia, because they tend to cause confusion as well, they have antimuscarinic effect. So we always have to check for the comorbidities. ऐसा नहीं है कि हम हर पेशेंट को हर मेडिसिन दे सकते हैं. We have to check for the comorbidities, and in those patients then we select one appropriate drug and we give it to the patient.
थैंक यू वेरी मच, थैंक यू वेरी मच.
Dr. Farooq, now the last question is that Dr. Savitri has written. This shall be our last question because
sir.
we have already taken extra time. So please, can you read her question in the chat box, or should I?
Sir, I can't see her question.
Right. Yes, because we just ended. Let me tell you, how long do we need to treat patients before any effect is seen in distal symmetrical diabetic peripheral neuropathy?
With alpha-lipoic acid, what I have studied is usually 3 to 6 months, but I can check the literature again. Yes, for painful neuropathy, if you are treating painful neuropathy, then usually the effect should be there in 4 to 6 weeks time. But for example, if you are using some neurotonic, for example, alpha lipoic acid, B complex, so usually we give patient 2 to 3 months time and then we reassess. For mycobalamine, what I have studied is they tell us they give it in high dose for 1 month, then you can stop, then reassess, and then you can give it again. But they should be used in short term. For alpha lipoic acid, studies are saying you better use it in long term. For example, 3 months, 6 month time, and then reassess.
Thank you very much.
Right. Right. Thank you, Dr. Saqib Ali, for
Thank you, sir.
giving us a very elaborate,
It was
nice
an honor
presentation.
to give a
I
presentation.
know, being a physiologist and a practicing physician, this topic is of many hours, if not days. You
Yes, sir.
presented it concisely in 1 hour, very effectively. I thank to all the participants. I thank Dr. Savitri to join us from Sri Lanka, and we may be expecting Dr. Saqib to present us some similar thing on some another similar
Sure, sir.
topic.
Inshallah, some other
Yes.
time. Yes,
Yes.
sure.
So thank you very much. Thank you, everyone. We can now leave the meeting.
Thank you, sir. Thank you. I
Thanks,
hope this
everyone.
session was helpful
Thank
to
you,
everyone.
sir.
Yes,
Thank you so much.
very useful,
Thank
very
you.
useful, very
Thank you,
helpful.
sir.
And
Thank you, sir.
hundreds now watch this on our YouTube channel. Now the online participants are few due to Sunday, but hundreds of the people watch. It shall be uploaded on our YouTube channel. Thank you very
Okay,
much.
sir. Thank you, sir. Thank you, sir. Assalamu alaikum.